Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all that ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in to the Tate Chronicles. Join me as we cut to the fog that exists at the leading edge of healthcare technology. My guest today is James Threatte, who is a senior account manager as well as a test proctor at the Drummond Group. Drummond Group is well known to most of my listeners. It's a ONC Authorized testing laboratory and certification body, as well as a leader in regulatory compliance, security, and risk management. James has a background similar to mine that includes medical practice administration as well as EHR product development and implementation. James, welcome to the Tate Chronicles.
Thanks, Jim. Glad to be here.
Why don't we just start a little bit? Would you just tell us a little bit about your background and your experience in healthcare?
Sure. As you mentioned, I'm a senior account manager and test proctor at the Drummond Group. Been doing this for about 2.5 years now. Prior to this, I was a product manager at an EHR company, and we achieved certification in 2018. So I've been working in the certification field for quite some time now. Prior to the product manager, I was working at the EHR company for about 10 years, starting at the very beginning. It was a startup built around the new HITECH Act and Meaningful Use Stage 1. And then even before that, I was managing a clinical practice which implemented EHR in 2003. So it's been a long time in this industry, and I feel it's very important, and I'm glad to be here to spread the word.
I think one thing that somebody in your position, some real value you bring, James, is that you come from the provider side. So you were on the side of providers. You know what's involved with the actual delivery of healthcare. So then moving over to health information technology, you bring that knowledge of what it's really like to deliver care. The whole concept of the testing and certification of health information technology or EHRs, I can still remember the days before there was any certification process whatsoever. Back before CCHIT, I think maybe they did their first certification. I want to guess, I think they were formed in 2004. Maybe their first certification was in 2006. I may be off a year or so there. But before that, it was the Wild West in terms of the features that were incorporated in EHR. So the real need for testing and certification, what are some of the reasons why you think it was important for us to go down this road of certification?
Sure. So before the whole Meaningful Use Stage 1 law came out, there was a lot of variability in transmitting and holding patient records between, paper charts and local server database EHR products. We've seen it move on to the web now, and the standards that have been implemented for Stage 1 through Stage 2, 2014 edition, and now Stage 3, 2015 edition, and Cures update, the goal has been to standardize the transmission of data. Before that, you could receive, it could be anywhere, what you would get, and it was often not compatible and really not really usable. So the current program is called Promoting Interoperability. And so that's focused around file formats and API and clinical quality measures and things like that. Before this, the program has changed names a couple of times, but in previous iterations, the goal was to lay out like a minimum set of functionality that providers needed. And over time, I think everyone has kind of built that functionality. And so it's just the interoperability piece that's what we're focusing on now. And, there's many, many use cases for interoperability. Whether you're going into a emergency room in a different town than you live in, or you have multiple providers on your team and they would want to see, what the other providers are doing with your care. So that was not possible before. I mean, before you would have a paper chart and you would have to fax it. And there was often a lot of time that it would take to do that. You had to sign a form, and then they could take 1 to 2 weeks to make photocopies and then send that out. So now it's immediate. You can download your records from the patient portal and give those directly to your other providers. So we've come a long way, and there's even more benefits coming out of the new standards that are on the horizon and that are being implemented now, such as FHIR APIs. So interoperability is a great term, but lots of vendors would say that they were compatible and that they were interoperable, but it turned out that they were not.
Right.
So doing testing actually allows us to point out what's not conformant and what's not going to be compatible. And so I've, worked with quite a few vendors over the last 2.5 years, and trying to find, a standard format for all of them to be able to send and receive data. And believe it or not, even after all this time, they're still not all exactly interoperable. There's lots of differences in the standards and different ways to implement different things. So they're not exactly the same. And so we're working towards, a day when identical health data sent and received from a system is going to be exactly the same at a different provider's office, as well as, the general practitioner. So,
that's a big part of interoperability. Of course, we can have these regulations that mandate specifications and protocols for communication and code sets, but the actual workflow as to how a provider would, with a few clicks, be able to send the information on a patient that they want to send, and maybe send it to a emergency department or to a specialist. That varies quite a bit. And as you say, that workflow varies quite a bit from one system to another. The way I would love interoperability to be, but there's certainly technical challenges as well as these workflow challenges. You can go on vacation to another continent, walk up to an ATM, stick in your bank card, and get money out. And somehow there's behind the scenes all that magic that can check and distribute money to you there right on the spot. But because the back end is so compatible and those standards and the workflow has been agreed upon. In the whole terms of where we are in interoperability, I would maybe say 15 years ago was the beginning attempts of it. Of course, we had to have the code sets and things like that. But where do you think, James, we are in the entire trajectory? That's a question I like to ask. Where, hopefully, will we be in 5 or 10 years?
Oh, that's a great question. So the Cures Act took effect last year. The CMS Payer and Patient Access Rule took effect, over the last few months. And more features of it is becoming required, in the next forward couple months. So the developments around FHIR APIs, the Fast Healthcare Interoperability Resources Standard, has come a long way in the last 10 years or so, but the progress is accelerating. So now we have implementation guides for patient access as well as payers being able to exchange information. So one of these great use cases is, a doctor sees a patient, they may or may not be able to get records from a different provider, but they will be able to get records from the insurance company who has, records of just about everything.
Yeah. Mm-hmm.
So that's another potential source of information that will become available to providers. And there's other things like provider directory and drug formulary, which will enable consumers to do comparison shopping. So there's a lot of great developments that are right around the corner. And I think 5 years from now, we'll be having a lot more progress than we've had in the past 5 years.
Maybe 3 or 4 years ago, one of the buzzwords was a PHR, or a personal health record, where either on your smartphone or some other application on your computer, all your information would be gathered together. And it's more than a portal, because we have a portal pretty much for every hospital we've gone to, or every provider network or individual provider we've gone to. But there was, I guess, a lot of technology in promise that PHRs are really going to take off. And it seems to me that most folks, I could, be good to hear your opinion, really don't want to maintain all their medical records. The whole concept of PHR really hasn't taken off. Now, portals seems like have really taken off, because a lot of people have found the advantage of, instead of having to call their doctor's office for a refill, they can go to a portal, make an appointment, schedule things. It's easier. But that cultural shift to, patient-centric records, I was, I guess, a little surprised that didn't really take off like I thought it was going to be. Any thoughts about that, or maybe you're an advocate of PHRs?
Yeah, I still think it's a great idea. There's been some barriers to implementation. For example, it's, according to federal law, it's illegal to have a national patient ID. So that harms a lot of that effort. There are incompatibilities, even within the FHIR standard. Version 2 is not compatible with version 3. So we've all centered around version 4 now, so that, that standard will enable these kinds of things. And I think that with your personal health record, if you store it on your phone or anything like that, I think for the average consumer, it's not all that informative to store, this kind of data and to manage it, especially if the provider is really the one that needs access to it. So if there was a way that the PHR could interact with all of your providers and be able to take data from one provider and send it to the other and make sure everybody has the exact same information, that would be useful. Mm-hmm. But until we get to a point where you can do that, it's not going to really take off. Plus, and on top of that, obviously, HIPAA will limit what can be done there. Yes. Because people are afraid, not that it's not possible, but people are afraid to be sharing health data, because, who knows what the security on the other side is going to be. And there's so many risks around sharing patient data. In fact, when I first found out that they wanted to require APIs for healthcare, my first thought was, oh my God, you want me to secure this patient data, and now you want me to put it out on the internet?
James, I hear that all the time. And when I talk to vendors, when they first come up against that requirement, they don't believe it. They say there's no way we're going to allow some third party to access our data. But, exactly. If a patient gives permission, which, can occur, and that access is required for a base 2015 base EHR, that API standard. I know you spent some time as a practice administrator. Was that a specialty practice or a primary care? What kind of practice was that, James?
It was a specialist. It was ophthalmology.
Yeah. And so maybe not so relative to that field of healthcare, but the whole area of technology expanding into remote patient care or remote patient monitoring, I see fantastic potential in that. And it seems like the technology is already there to do that.
Absolutely. Yeah, and with the past year, telemedicine has really taken off, and this will enable that, which you couldn't do before, really. Now you are able to send and receive health information, so that will increased the value of telemedicine, because there was only so much that you could do remotely as
Right.
a provider with the patient. So without the information, I mean, it really is just a, conversation with the provider. They can't really prescribe a treatment or make a recommendation without sufficient information. But now they will be able to.
Those patients who have chronic diseases, to be able to monitor them remotely, the capabilities there, the devices are there, everything's kind of been worked out. It still seems like the reimbursement side of it has, some things to be sorted out. But I think that is a great area where technology can really extend healthcare with that remote monitoring. One of the things in the Cures Act that kind of went into details in the Cures Act was these new conditions and maintenance of certification requirements. So this is beyond just achieving successful testing and becoming certified. There's these maintenance requirements. Could you tell us a little bit about what some of those maintenance requirements are?
Sure. So what they realized was, some products certified in 2016, and then they hadn't made any changes to their certification or done anything with it in the meantime. But users are still using it, and the technology is improving. New code sets are coming out, and new functionality is available that wasn't available 5 years ago in 2016. So what ONC decided was there was certain things that are important for certification that were missing. So for example, there are, within the conditions and maintenance of certification umbrella, there's real world testing, there's information blocking, there's APIs, there's assurances and attestations and so on. So there's a whole lot that they realized was not part of the original certification program. And to their credit, instead of creating a new round of the program, so like there was 2011, 2014, 2015 edition. So instead of creating a 2020 edition, they just decided to add on to the 2015 edition. So it makes it a lot lower hurdle for existing certified products to stay compliant. Things like real world testing was an idea that was born out of the original certification requirement, where there was a safety enhanced design test that each EHR had to perform, but that was it. Nobody was required to do any kind of user-centered design testing after that. But it's very important because, I see articles all the time that providers are being burned out because of the EHR, and there's usability issues and all that. So ONC said, let's make it so that vendors have to pay attention to how their product is being used in the real world, which I think is a great idea. And there is somewhat of a burden, but it's not a huge burden. And you're given lots of time to work on it. Between the time that the plan is due to the results, it's over a year and 4 months or so. Other things are like info blocking, where vendors were withholding patient data and not allowing their customers to transfer to a different EHR, or patients wanted their data and it was not possible to get it out. So there's lots of things that were put into the conditions and maintenance of certification that were really missing from the certification program that encourages interoperability.
One of the things you mentioned, James, around the real world testing, and that certainly makes sense, because when a vendor comes to Drummond or one of the other ONC authorized testing bodies, the technology and functionality as it's tested, it's tested in a relatively pristine environment compared to a busy office and real workflows. And so it makes sense to have that real world testing. Now, I know there's still, this is the first year of it, and there's still some things being figured out, because sometimes people may have a certified product, but either it has not been released yet and there are no users yet, because it's got to be, the emphasis is the testing and data that's gathered is in a real world environment, or some of the functionality that's required to be real world testing is such that practices may not actually use that functionality, the ability to maybe generate these CCDA files, things like that. Some practices don't do it. So I know there's some things being worked out this first year, but certainly real world testing is needed, and I think it's a good extension of making the water safe for everybody to get in the deep end of the pool, so to speak.
Yeah, and to add to that, this is the first year of real world testing. And so ONC has said that they really just want to see what vendors come up with this year. They're not really going to come down on the plans. Drummond Group, as the authorized certification body, is not evaluating the real world test plans. We're just doing a completeness check. Mm-hmm. And then ONC is going to look at those plans, and then they may or may not come out with clarifications and additional guidance for the next round, next year. So a lot of hay is being made about real world testing, and it's just like you're saying, I get a lot of questions about, hey, you know what, nobody actually uses this functionality.
Yes.
Which saddens me in a way, because all this work that has been done to promote it it's never being used. But I can say from my own personal experience that is true. When I was working on implementing 2015 edition changes, we actually went back into the logs and looked at how many direct messages were sent, how many CCDAs were received, how many were sent. And they were most of the entries in the log were our own QA department doing testing on new builds. They were not users using it. It was just our internal people doing it. So yeah, I hear that and I see it. And I think that it's also going to take some time for providers and healthcare professionals to get used to doing it.
Yeah. The one thing about storing machine readable, human readable, codified clinical information is one thing. And then that big jump to the actual exchange of it is a whole thing altogether. And I think with the real world testing, part of it is if areas or functionalities identified that's not being used very much, over time, as the real world testing occurs and the plans are written, those who gather all that data at the highest level will be able to see what type of adoption is taking place over time. So I think it can only help. There's no doubt about that.
Right. And in real world testing, it is acceptable to set one of your metrics as how many times was this done in the year.
Yes.
And 0 is an acceptable metric. This is acceptable response. So that's okay if you state that nobody really used it, but it's just that they want to make sure that you're looking into it, that you're monitoring it, that you're checking it.
That kind of reminds me when clinical quality measures were first included in certified electronic health records, how somebody actually scored was not the issue. It's just whether you could accurately capture that information. And then a few years later, under the MacroMIPS program, how well you did started becoming important. So,
yeah, I remember there was like percentages. You had to have 10% of your patients enrolled in the patient portal and so on. But
yes,
you can't force a patient to enroll in the patient portal. So they rightfully removed requirements like that, and they just wanted to know how often is it happening.
Exactly.
I think it's much better.
James, I can't believe it, but we're almost totally out of time here, and I didn't get all the way through my questions. So we're going to have to put those questions down for a future conversation. But before we go, where can listeners go if they want more information on the services of the Drummond Group?
Yeah, drummondgroup.com has a list of all of our services. We actually offer quite a bit more than the healthcare compliance services. We have like real world testing advisory services. We, as I mentioned, the 2015 edition Cures Update certification program. We also do CMS payer and patient access program fire testing. And then a whole load of other security and compliance services that are offered by different business units within Drummond Group. So you can go to drummondgroup.com and take a look. We have quite a bit of information there and links to where you can find even more.
Well, great. Well, thanks for that. And to our audience, thanks for joining me on this episode of the Tate Chronicles. I offer a special salute to my guest today, James Threatte of the Drummond Group. James, thanks for coming aboard today.
Thanks for having me.
You can find more information on this show's program page at healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.